What's up, FRT community? So today we're going to kind of flip the script on you, okay? So I know you're probably looking forward to another educational video. I've got another one planned for you later this week. But for today, I want to share kind of a new avenue I've been exploring where I've just been spending time talking to respiratory therapists and truly impactful respiratory therapists. And so I've started a new episode, and we're going to call this RTalk. That's what it's called. Now, if you like what you're seeing, I want you to show love for our guest by smashing the like button. I also want you to put comments below, questions for our guest. And what we're going to do is we're going to do a follow-up segment in a week or 2 weeks, and we'll come back and we'll answer those questions with the very same guest, okay? And as always, if you're not subscribed, please hit the subscribe button. We would love to have you as a member of the FRT community. Now, without any further ado, let's get into this week's interview. But just before that, if you want to do an interview, if you want to do and you want to have some RT talk with Coach, send me an email, respiratorycoach@gmail.com. I don't care if you're a student, a new grad, experienced therapist, or a manager, or a director. Don't care what level. I'd like to talk to every single person I can, and we'll feature you on this as well. So now, without any further ado, let's talk with JJ Valdez. What's up, future respiratory therapist? Coach here with you, and I have a special guest with me today. And before I actually let him talk, I'm going to tell you a little bit about him. His name is JJ Valdez. Now, JJ started in the field of respiratory therapy back in 2008, where he graduated with his associate's degree. He went on to get his bachelor's degree later after that. Since then, he's served multiple positions: staff therapist, team lead, educator positions. And he's currently working towards his master's degree, which just so happens to be how we met, JJ. And so really fortunate for the way this has all kind of worked out, because I feel like I've met a good friend in life. And so, I appreciate you being here, JJ. And, his focus has been on adult critical care. He's worked with all populations, but his focus has ultimately been on adult critical care. And I'm just thankful to have him here. Now, I will tell you this before you look and you judge and you say, what the heck am I looking at right here? I will tell you this. This meeting that you are watching right now actually was arranged about 30 minutes ago. I said, hey, JJ, we were talking on the phone. I said, JJ, what are we doing talking on the phone? Why don't we put this on Zoom and share this with the future respiratory therapists and the current respiratory therapists that are out there right now? And if you don't mind, JJ, I'm going to tell you kind of my perception of what happened. He took a big, deep breath in, and he was like, I'm not sure. And I said, well, what do you mean? I said, you got the, you like, what do you mean? And he was like, well, I need to put sleeves on. I laughed, and I said, dude, you're in the Virgin Islands. JJ's currently working as a traveler down in the Virgin Islands. And I said, you don't need to put sleeves on. And sure enough, here we are with JJ with no sleeves, sunglasses, looking sharp, enjoying the Virgin Islands. How you doing today, JJ?
Man, I'm happy to be here. Joe, thank you so much for doing this. Like you said, we met through the master's program, and I'm truly thankful that we met, because I feel like I've met a brother. You said a good friend, but I feel like you are my spirit animal. When you did your intro for one of our classes, I was like, this guy, I'm texting him right now. And we met and communicated within, that first week, and it's been a great mesh and matchup ever since.
Yeah, I agree with that 100%, man. I kind of feel the same way. So I did say good friend, but you're right. I think spirit animal or brother might be better, because it does seem it's just cool how people's lives converge. And for all of you therapists out there watching this, like, you got to be able to be aware of when you converge with someone else who has the same mindset at life that what you do. And when you find that, you have to hold on to it. Now, before we get into actually hearing some of JJ's thoughts on respiratory therapy, here's what I'm going to ask you to do. If at any point you like what you're hearing, be sure and hit that like button. If you're not subscribed and you find value in this, then be sure to subscribe. We'd love to have you a part of the FRT community. And more important than all of those is that if you have a question that you want JJ to answer, I want you to put it in the comments below, because what we'll do is we'll set this up again a week or 2 weeks from now, and I'll come back with your questions and you'll get your answers from JJ. So having said that, let's jump into it, JJ. Now, I know, you've spent some time working in various facilities as an educator and as a preceptor for students. And one of the things that is really a big pet peeve of mine is this idea of, here's what's going to happen. So to all you future respiratory therapists, here's what's about to happen. You're going to graduate, you're going to get your license, you're going to go out, and you're going to have a preceptor that is going to tell you that you're smart and you know what you're doing, but you need to work on time management. JJ, what does time management mean traditionally?
Yeah, so traditionally, management is, get as much work as you've done as quick as you can. That means we've talked about it before. Some people are getting their therapy done so they can go to breakfast. That's the priority that's on their list. I'm sorry, can you hear that, Joe?
We can, but go ahead.
Background.
It's not that bad.
Okay. I can share a story real quick. I used to be a youth baseball coach, and I loved my stopwatch. I would time people from home plate to first, from the catcher throwing from behind the plate to second base, just to make sure that all of the numbers were right. And so I used that same approach whenever I was precepting a couple of new hires that we had. And I was telling them, look, you guys are spending about 8, 10, 12 minutes in the room. In order for us to get all of our work done in a timely manner, you're going to have to scrape that down to about 5 minutes, if not less. And
wow, after
you and I were having a conversation about that, I was like, there's no way. That's not therapy. That is passing meds. And for me, as a preceptor at the time, I was doing what I was taught to do by my upper management. Should I have taken the higher road and done what's best for our patients? Absolutely. Is it okay to say that you're wrong? Absolutely. But as long as you're growing and you're learning from those opportunities, I think John Maxwell says, the best teacher is evaluated experience. So not only have I put those experiences to thought and I'm now learning from that, I'm changing my practice so that I can impact the future in a different way.
Nice. So when you had your stopwatch going and they were at 12 minutes, you said, we got to get down to 5. Were you essentially telling them you got to figure out a way to cut something out? Is that what you were essentially saying?
Yeah. And really it was, they were spending too much time with the patients. They were talking with them. They were communicating. They were building a rapport. And that was great. They should have been doing that. That's exactly what they should have been doing. And, I was saying, you got to cut some of this time off so that we can get all of our therapy done.
So what I'm hearing here is that you were telling me that you were actually precepting people to tell them you don't have time to build a rapport. You don't have time to do a pre and post assessment. You don't have time to do the details. You're essentially telling them it's time now to learn how to cut corners so that we can get more done in less time. Is that true?
Exactly. Yeah, now, that's exactly right.
Perfect. So now, what is your new idea of time management? When you think about time management now, what does it look like?
So time management takes a while to evolve, takes a while to grow. You and I were talking about it, I think it was earlier this week, but growing up, when my parents gave me a chore list, a to-do list, I had X amount of time to get all of that done, right? And I think a lot of you guys can relate to that. And same thing with therapy is whenever I was first taught, whenever I was coming up in the profession, I was given, 60, 70 treatments. My expectation from my work ethic that I knew from my parents was get all 60 or 75 of those treatments done. And it didn't matter how that happened. And the way I was taught is you start at the first room of that floor, you go around, starting all your therapy to the very last room of that floor, and then you come back and you start at the front again and you turn everything off. Now, again, that is not respiratory therapy. That is passing meds. These are bad habits that were ingrained in me 13, 14 years ago. And it's taken time for me to say, to have the confidence to step up and say, no, this is not how we do this. This is not respiratory therapy. This is passing meds. And in order for us to get to the direction and the trajectory and the places we want to go, we've got to do way more than just pass meds. So having that list of 60 treatments, having that patient list where I'm getting all of this therapy done, looking at what is more impactful, right? Being able to knock out the 60, 70 treatments, or assessing my patients and evaluating them to see who needs their therapy and who needs to be weaned off. One of my biggest pet peeves is a patient that comes in for respiratory distress that's on Q4 nebs and is discharged and they're still on Q4 nebs.
Yeah.
What did we do? What did we do? How do we progress that patient through their care?
Right. Yeah, that's a crazy. You're exactly right, man. That's nuts. And then they go home and the Q4 nebs just magically stop and were never needed.
They're done.
They're done.
Yeah, they're done.
Yeah, you're right, man. That right there it's blown my mind for a long time. I really like the way you brought back in the mindset from a child, from what we're taught to do, which is I think what most people do. I think most people look at a job and they think, I want to make my employer happy. So if my employer is asking me to do X amount of therapies or X amount of workload, then to satisfy my employer, which I believe is what most people want to do. I think they want to satisfy their employer. Now we're talking about respiratory therapists. So you graduate, you go out and start working, and now you're no longer a student. Now you're an employee, and you naturally want to satisfy the request from your boss. And man, I don't know how to fix this. I don't even know where to go on that conversation, because my instinct is to say, look, guys, just slow down and don't do them all. But I understand that as a new grad, that's not going to work, because you're going to be seen as somebody who can't do the job. So what are your thoughts, man? Where does the transition happen to where you go from new grad, have to fulfill the necessities to keep my job and show that I'm competent and that I can do what I'm supposed to do, but now I'm going to start doing things the right way? How does that look to you?
So yeah, you go back and you look at a new grad that's coming on as a new hire, and let's say that they're taking a little bit longer to get their work done, right? They've passed orientation, they're out on their own, and 30 minutes later, the rest of the staff is coming to check on you, right? And at that point, you're labeled, right? You're labeled as slow.
Yep.
As slow, not thorough.
Right.
Right? So what is the true nomenclature? Are you slow or are you thorough? And what do we really need to be doing? And again, going back to my teaching and what I learned, right? Start at first room, go around and knock them all out. And then you go back to the first room and take them all off. That's, again, the mentality and the teaching that needs to go away. It just needs to stop.
Yeah.
But going back to how do we fix it from here? One of the ways that we were able to build time management when I was in an education role was through an internship. They were hired in May, and through the summer, they spent a vast majority of that time shadowing and following other disciplines. They were shadowing and following physicians, admitting docs, ER docs, intensivists, residents. They were going into the cardiothoracic ICU, in the OR suites, watching cabbages. They were seeing so many things through the summer, just getting a really good idea of how a patient experiences their time in the hospital. Then In the fall, we were able to deem them competent in doing some very, benign tasks, very mundane tasks. And they weren't allowed to do any initial assessments. That was left to the credentialed practitioners. And they were able to do oxygen checks, SBNs, ISs, and EKGs. So they were doing very basic, first semester type therapy. But the goal was not for them to knock out as much therapy as they could. The goal was for them to build on the assessment skills that they learned over the summer, so that in the fall, they could get to a point to where they could take on the goal was from the fall to the spring to be able to time manage. So they were given 9 months to learn time management. 9 months to learn time management. Yeah. And then by the time they graduated, they were well ahead of the curve. They were well ahead of the game, and they knew how to handle and time manage effectively when they were given appropriate amount of time.
Nice. I'm going to do something here real quick, because something you said is something that I've said just in a recent week. I'm going to actually put it up here on a board for everybody to see. It's slow versus thorough. And I'm gonna actually, as you talk, JJ, I may just throw some words up here, some key points that you make. But this is
absolutely,
man, like there is a difference in being slow and being thorough, 100%. So I appreciate that, and I like that idea of the internship and how it worked out, and how it kind of leads into kind of an easing in, to the position with a focus on what's right. Now, we're going to talk to the class of 2021 here for just a second. So, and you've kind of already been doing that, but let's talk to the class of 2021. Now, you guys, we know, man, your education got messed up. You've all been virtual. COVID jacked it all up. We all know, okay? But, JJ, what is the #1 most practical piece you have for graduates of the class of 2021?
The most practical advice is something that I've tried to live by throughout my entire career, is be a sponge. You have to be able to absorb as much information and data and habits as you possibly can. Now, with that, be careful. You can't sponge up those bad habits. You have to be able to decipher which habits you want and which habits you don't want. A lot of times with students, I would tell them, you're going to see some really good therapists, and you're also going to see some really bad therapists. You have to be able to figure out which ones those are. And you build your practice based off of the good therapist. Now, you're not going to do it exactly the same way as, Joe does it or I do it. You're going to have your own practice. And that means you have to be able to look at people who are doing it right and people who are doing it wrong, and kind of filter through that so that you can build your own sound practice.
Yeah. What you just described is kind of when people ask me, or they say, hey, how did you become the therapist that you are, or whatever, man, my answer is usually simply this: I consider myself nothing more. None of this is Joe. This is nothing more when it comes to respiratory therapist, Joe. This is nothing more than a big transformer of all of the good that I saw in my early years. And I said, I want to do that. And I put that in my box. And I want to do that. And I want to do that. Even as an educator, I feel like I am nothing more than a transformer of the best that I saw. And it's led me to a successful career and a lot of fun. Also a lot of frustrations, because you find yourself coming back to that statement that if you're watching this, I've said this before, underachievers hate overachievers and overachievers hate underachievers. And if you put the very, very best of everybody that you see in your own practice, you will become an overachiever, and you will be hated by the underachievers. And that's just the name of the game. Let's talk about one of the problems in respiratory therapy right now. this is probably, I can't believe it's still going on in 2021, JJ. But let's talk about concurrent therapy, congruent therapy, stacking therapy. Why is it a problem, and why is it still happening in 2021?
Wow. And you go back to my training and what I taught, or what I was taught is you stack the entire floor.
Yeah.
It wasn't just stacking 2 or 3. I was taught to stack the entire floor. Now that is just wild, right?
Yeah.
As the educator, as a preceptor, what's that?
I did the same thing.
Yeah.
Like, I learned the exact same way. I'm gonna let you finish, and I have a follow-up question for you.
As a preceptor, as an educator, I was teaching our staff to not stack more than 3 treatments. I was teaching that you could assess and get the assessment and evaluation and the starting of the therapy going within 5 minutes. That's where the 5 minutes came from, okay. Right? Because a neb lasts 12 to 15 minutes, right? Unless you're running at 10, right?
Right.
That's a whole different subject. But it takes about 12 to 15 minutes to run the entire nebulizer. So I would have them do an assessment, start their therapy, jump to the next patient. And then, as a new hire, as a new therapist, I wouldn't let you do more than 2. I would let you kind of build up to the 3, right? You have to graduate to do more.
Yeah.
Again, just these wild ideas that are just wrong.
Right.
They're just wrong. But at the same time, what I was being told is, if you're not able to multitask, you're not an effective therapist. Like, think about that.
Yeah. Well, the interesting thing there is that I do think you need to be able to multitask to be an effective therapist, but not in the sense of what you're talking about right now. Multitasking does not mean stacking 8 nebs.
Right. Absolutely.
So multitasking is 100% important, but not in that frame of sense.
Exactly. So I've heard Michael Hewitt speak, and he gets fired up about this. You can see that fair skin turn bright red very, very quickly whenever you get him on this role. But it really should not be happening. That's a prime time for us to dig into that patient's chart and figure out a little bit more about their history, do a little bit more of a patient interview, see where the care plan is going. That way we can communicate with our physicians and our mid-levels to say, look, we've got John Smith here, who's not had a pulmonary history, or they're here for cardiac reasons, and we've got them on albuterol. We need to really evaluate and see what's going on with these folks. If they are a pulmonary patient, then we can start to do our education right there. Let's do smoking cessation at that time. Let's look at what the pulmonary rehab looks like in the future. When's their last sleep study? When's their last PFT? How can we progress these folks through? Are they still smoking? Are they switching over to vapes? What does that look like? And there's just so much more that we can get done evaluating our patients, staying in that room. And it's not just monitoring the heart rate. It's not just monitoring poor adverse effects. It's getting to know that patient, building that rapport, and teaching them. That's what we do. We teach our patients and we therapize them, right? I don't know if that's a word, but we do therapy with them and we educate. So many people say they're not educators. They can't teach. But guess what? We should be teaching our patients all the time.
Yeah, man. It's funny because I had a chance to interview one of our area leaders just recently, and he talked about one of the biggest ethical dilemmas that he thinks the world is facing, or the world of healthcare and respiratory therapy is facing right now. He kind of went in 2 different elements. He talked about not only patient autonomy when it doesn't match caregivers' thoughts, but he also talked about this idea of we have got to shift our mindset from taking care of sick people. When people come to the hospital, we're going to be there to treat them. What he was talking about was, no. The idea is let's educate them so they don't have to come to the hospital. And that time during that therapy is the time where, like you stated, the patient rapport happens, and you actually have a chance to actually, like imagine if you actually educated a COPDer on how to properly use the Symbicort.
Right. Absolutely. Here's the proper use. Here's the proper use of how to get the most out of this medication that you possibly can.
Yeah.
I hate to do this, but I was making excuses for myself when I was a brand new therapist. I graduated a month after turning 21. Most of my patients were double my age in years, right? They didn't want to hear this young whippersnapper tell them how to do their thing, how to take their inhaler, how to take their breathing treatment. They've been doing this for X amount of years. They don't want to hear from you, right? So I was making excuses for myself, but that's not true. You are the educated professional. You are the one that went to school, that passed your boards, that knows this stuff. So you are the expert in the room, not the patient that's been there for, 7 days, just still waiting on discharge orders. So absolutely take ownership of who you are, take ownership of this profession, and don't let your insecurities of your age, your lack of time in the profession, your anything else, any outside influence change what you should be doing for these patients.
Yeah, man, I love it, man. I love what you're saying. It's just like, my mind is blown every single time when you go and you give that patient that COPD, and they're like, I do it this way. Well, that's the opportunity. That's the point to where your expertise becomes valuable. And that's what we talk about when we talk about disease management and disease education, which is going to reduce future and recurrent admissions. And only until we find that and we are actually in the room with our patients for those times, are we even going to have the opportunities to talk with them and make this happen. So I agree 100%.
Let me ask you something, Joe.
Yeah.
Have you worked at a facility that has a disease or discharge specialist in the respiratory realm?
No.
So I have. We had a therapist that was working with the discharge group to educate our pulmonary patients at discharge, whether that's helping them get set up with O2, their inhalers, whatever that may be. So we created a position for a whole new FTE for our respiratory patients to get information that they should have been getting while the therapy was being delivered. Now, when we talk about impact and we talk about hospital savings and we talk about all of these things, right? That FTE could have been placed back into the respiratory department, and that busy could have been reduced by one more person, and you could have spent more time impacting that patient, saving the hospital, right? And what's again, we go back to what's more impactful, knocking out the 60 or reducing that 60 down to 30 because that's what's necessary, and teaching and educating those 30 that you have time with on their disease, on the best way to manage it, and how to stay the heck out of the hospital. I like you and all as the patient. This isn't anything personal. I just would rather see you at the grocery store than here at the hospital.
It's funny because I think you read my mind on that when you asked me that, when you said, have you ever worked at a facility with a discharge respiratory therapist, like a focused on discharge education? And I said, no. And you started talking, and I immediately went, genius. And then as soon as I thought genius, I thought terrible. Because you're right. That is a job that if we did our jobs correctly, wouldn't even need to be needed in the first place, because that's everybody's job. That's every respiratory therapist's job, is to be educating patients on proper home use and care post-discharge. There's no sense. But you're right. We're too busy running around seeing as many patients as we can. We don't take the time, man, look what it comes down to, man. We don't take the time to talk to our patients like we should. And if we did, we would probably learn so much just from them. We would educate them. They would learn so much from us. And this whole conundrum of stacking therapy would solve itself. And so
Absolutely.
I think we've spent enough time on that, Horace. I want to ask you a question, kind of a personal question. I'm interested in how invested are you personally in the future of respiratory therapy, and what are your visions for it 10 years from now?
So, big topic, right? This is pretty broad. But you look at our history. We are in I don't want to say our infancy. I like to say we are in our preteen years. We're still trying to figure out who we are as respiratory therapists. And part of where my passion is pushing our scope, figuring out what that means. Because you look at the scope of practice across the board at all of the different respiratory boards in every state. Every state is different, but every state has something in common. Every state says that if the physician orders it and you have a competency in it, you can do it. So when I was in Texas, the group I was with, we started placing central lines. To my knowledge, we were the first group of respiratory therapists in the state of Texas to place central lines. Again, a procedure that's typically left for mid-levels and above.
Right.
Why did respiratory therapists get to do this? Well, we had a fantastic physician champion that said, these guys are doing some really cool stuff over here and they're making, some splashes in different areas of the hospital. We trust them to do a good job with this procedure. So we were taught a procedure that was at the mid-level position and up, typically. Now out here in the Virgin Islands, we don't have a license. We go off of the license that we have back home or stateside. So what does that mean? That means that, again, if a physician orders it and the hospital has deemed you competent, you can do it. So we don't have a pulmonologist on this island 10 out of 12 weeks. There's a pulmonologist that shows up for 2 weeks every 12 weeks. So the respiratory therapists have a lot of autonomy. They have a lot of autonomy. And the folks that I work with here are very sound clinically. My question is, can we be deemed competent in chest tubes to decompress a lung? Can we be deemed competent in thoracentesis, especially with ultrasound guided and POCUS, point of care ultrasound needling? So that opens up a whole new scope. Bedside tracheostomies, the percutaneous trachs. I've been part of assisting, but what's to say with a surgeon there to deem us competent that we couldn't help these folks, later on down the road? So our scope of practice is wide open right now. And as long as we have a physician's order and are deemed competent from that facility, we can do anything. So that means the door is wide open for the future, for 2030. What does that look like? And I think we're actually at a crossroads. We're looking at, do we want to march to the tune of the physician's orders, similar to what nursing does? Now, of course, they have their clinical input that the physicians listen to them, but we also have our allied health, the speech therapy, occupational therapy, physical therapy, who get the evaluate and treat order. So we're at a crossroads right now. We can move towards our allied health folks and be evaluate and treat, or we can go into the nursing side of it and march to the tune of the orders with clinical input. And I think this kind of jumps into a whole different topic of bachelor's prepared versus associate's prepared, master's prepared, PhD. That kind of gets us into a whole different topic there.
Yeah, man, I think you're right. And it's funny you brought up chest tubes and thoracentesis and those things, because one of the things, if this question was to ever be asked to me, one of the things I would say is that 10 years from now, I would like to see 90% fewer aerosolized medications, and I would like to see the RTs at the bedside. I would actually love to be able to walk into a facility and say, hey, nursing staff, you guys work so hard and we love you and we're best friends. Like, I think nursing and RTs, there's always this kind of like internal battle between them, but really what we are best friends. And if you see it like that, then your life becomes a lot easier. And what I would like to say is, hey, let me take that chest drainage system off your plate.
Yes.
Let me get that off your plate. Instead of doing ABGs, I would like to see a lot more end-tidal CO2 monitoring happening,
Yep.
and everything, hemodynamic monitoring. We are competent. We learn about end-tidal CO2. We learn about chest drainage systems. We learn about hemodynamics. We learn about PFTs.
Absolutely.
Take the test, and then you never use that information again. And that's the future. That's where I see it, that right now we were operating in this very small, finite circle, and our scope is actually way bigger.
Okay, so let me get a question to you. The title, respiratory therapist, what do you think about? What is the core that you think about?
What you talking about?
As far as skills, as procedures, not as the global idea, but what actually happens at the hospital.
Oh yeah, what actually happens is definitely 100%. Breathing treatments, oxygen therapy, mechanical ventilation, not management, but documentation.
Absolutely. Okay. So do you think the respiratory therapy profession could use a rebrand?
100%.
What do you think about cardiopulmonary interventionalist?
I like it.
That is,
I mean, that's what we are.
Absolutely. You're interventionalist. You have to have the evaluation, the assessment. I'm going to go do what I need to. I'm going to see a problem. I'm going to intervene with that problem, and I'm going to help you get through this so that you can get to discharge. So that is something that I'm trying to push out here in the islands, is to change the idea of respiratory therapy to a cardiopulmonary interventionalist.
I like it, man. I love that term. First of all, I love that term. Like, I never thought about it like that. Like, all I want to do is just change it from saying we are a program of respiratory care to saying we are a program of respiratory therapy. I mean, if that would be one step in itself to get back to using therapy as a term, as a focus, instead of saying respiratory care. Like, right. I get it, but it seems like respiratory care kind of diminishes who we are. And the other thing I want to say right now while I'm on this, I just had this really interesting interaction on social media, and the word just was put in front of. And I realized, I was like, you know how powerful the word just is? When you tell somebody, what are you? What do you do? Oh, I work in healthcare. Oh, you're a nurse? No, I'm just a respiratory therapist. You just massively diminished what you are.
Right.
And we have got to get rid of that word just being before anything that we are going to call ourselves, because we're not just anything. Nobody is. Housekeeping or environmental services is not just environmental services. They are environmental services.
Absolutely. Let's say you get outside of let's say you get outside of the job realm and the worker realm, and you're just a stay-at-home mom. Yeah. No. There's no just to any of that.
Right.
You are what you are. Be proud of who that is.
Yeah.
You worked your tail off to get there. If you are set up to a spot to where you are, it's not just anything. You are.
Yeah. Yeah, I agree with you 100%, man. I got one final topic I want to throw your way, and then I'm gonna let you get on with your day. I know you got to work tonight, so probably gonna get ready for that. But talk about this bachelor push from the AARC. How much validity? What is it? Do you think it's real? Do you think it's valid? Do you think it's gonna happen? Do you think it's needed? What are your thoughts?
I want it to happen. Again, you go back to the associate prepared versus the bachelor's and greater prepared. Are we going to look at the orders, follow those orders, carry them out with some clinical input, or are we going to evaluate and treat our patients? So that being said, with the bachelor's, okay, so again, backstory with me, okay? I graduated in '08. I passed my CRT first blip out of the gate, and I was not going to get my RRT. I was that guy. I'm not getting my RRT. They're only going to give me $1 an hour. It cost me, what was the test? 300 a piece.
Yeah.
It was 300 a piece, right? If you pass the first time, luckily I was blessed enough to do that. So that's 600. But out of the income that I make from the $100 or the $1 an hour, I was only making $1,400 in a year.
Right.
And the monetary value just didn't make sense. It just didn't. Luckily, the facility that I worked for had a 1-year mandate from your hire date to have your RRT. If you didn't have your RRT within a year, go somewhere else. That was the expectation of that facility. And I am thankful for that, because I would have stayed in that CRT mentality. Shout out to my CRTs out there, but we need to continue to improve. Then I'm never going back to school. I'm done. I got my degree. I'm doing what I'm going to do forever, right? This is where I'm at. 10 years later, I'm graduating with my bachelor's of respiratory. So this hard-headed, individual over here, I'm slow, Joe. It takes me a while. It takes me a while to figure things out, right? But what I learned in my bachelor's program was more in depth than what I was able to get in my associate's program. It gave me more information into the body and how to treat, and also looking up information that may be cutting edge that's not even in our textbooks yet.
Yep.
So there were some skills that I learned, and I was a better clinician as a result from going through my bachelor's program. It was really interesting because in my adult critical care class, it was like every week that we were learning something, we were seeing that exact case in the hospital. So I was able to say, hey, look, doc, this is what we need to do. This is what, it was so relevant. It was on point that I was able to share an insight that was so fresh. You look at adult learning, and you have to have reinforcement. You have to have follow up with some of the techniques and the skills that you learn. You talked about hemodynamics. If you haven't looked at hemodynamics and played or monitored in that world since you graduated, right, then there's a lot that you've forgotten. You look at our conversation today, half of it, just because this is the way our brain works, half of the information that you and I share today will be gone out of what's, just because our brain has only so much information that it can hold. So yes, I'm a huge believer in that bachelor's program. I do think that it needs to be a bachelor's minimum. And does that mean that we can bridge to that? Absolutely. That will keep the doors open and help keep respiratory departments staffed with associates level therapists. But many of the places have tuition assistance.
Right.
And as long as you're signing a little contract, you can work at that facility and your tuition's paid for.
Yeah.
And then that goes back to the crossroads. Are we going to evaluate and treat, or are we going to read orders and follow through with some clinical input?
Yeah. Yeah.
With the bachelor's, I think we go more towards the evaluate and treat. You look at the other allied health, their master's minimum.
Yeah.
And if that's the direction we want to go, we need to catch up.
Man, I think PT is a doctorate, right?
They're doctorate.
They're doctorate level.
But
so
you go speech, you go occupational, you go some of those other ones. They're master's prepared.
Master's levels. This is actually an interesting topic, and the reason I like to ask this question to you and to other people that I feel like have insight on this is because you can actually go on my YouTube channel and you can actually find a video where I kind of dog this push. Because as an associate's degree level educator, I don't see much clinical skills difference in an associate's versus a bachelor's degree. Since the time of publishing that video, I have altered my mind. I've looked at it from different perspectives. And what I've come to realize is that it may not be so much about skills as it is about the dedication to the craft, the culture, and a much more deeper understanding of research, which is what you touched on. And so I think it's a big deal also. I see the benefit in it. I'm not a degree snob. I don't think that a bachelor's or a master's degree necessarily makes you smarter. I think it proves and speaks to your tenacity to go get something bigger so that we can all together be something bigger. And that's kind of why it's important to me and why I've kind of changed my position on this over the last, probably a year or so.
And going back to the John Maxwell point, right? Evaluated experience is the best teacher, right? You get other people's perspective, you chew on that, and then you can digest it, and then now you have a different outlook on things. Going back to where this whole conversation started, how was I taught to be a therapist?
Right.
To be a therapist, right? Go through, start at the first room, come around, and now 15, 14, 13 years later, right? Here I am saying absolutely not, beating on the table saying that is not how we need to be doing this. But that's the way I was taught. And back to the CRT only guy, right? I'm not going to do anything more than that. Yeah. But the more you get into it, the deeper you get into this profession, the more you understand that you need more. And especially with trying to figure out where we're going to go.
Yeah. Yeah, man. It's almost infectious. It's infectious. This is my, I asked JJ earlier, give me your number one practical advice for the graduates of 2021. Here's what my number one practical advice is. And I can't beat JJ's because his is the best. But mine, for any therapist out there right now who feels lost as a respiratory therapist, I'm going to tell you that all you have to do is reach out and find somebody to talk to. Because if you can find a JJ or a Teresa or a Crystal, and these are all people I'm telling you I talk to on a weekly basis, they fuel your desire to want to learn more. And you hang up the phone from them and you go get into Egan's and you learn more because you see that there's more out there to be learned. There's more knowledge that we still just don't have. So don't ever settle for that. I'm going to wrap this up right here. I've been writing some words down. We're just going to do a quick recap, if you will. First of all, we're going to stop saying just respiratory therapist, right? JJ had a phenomenal idea, and don't think about yourself as a respiratory therapist. Instead, why don't we rebrand it to cardiopulmonary interventionist, because that is a title that carries weight and actually tells you what you're doing and what you're going to get involved with. Also mentioned, JJ, and I appreciate this, we're at a crossroad. Are we going to continue to just follow orders forever? Or are we ever going to evolve into this state to where we are evaluating and treating, and the physician is actually listening to our input instead of just telling us what to do? I think that's a great idea. He was so on point. We're not in infancy. We're not a new birth, profession, but we're still not fully grown. We still got a long ways to go. And if anybody out there has preteens right now, you know exactly what state that's at. So you're right. We are still very, very young. He said therapize, which I think we made a new word today. But I like it. So, you know, are you going to therapize your patients, or are you going to actually take care of them and treat them and educate them, monitor them, take care of them? Be a sponge for all you new guys and all you new respiratory therapists. Be a sponge. Look for the good habits and what you observe and put it in your belt and take it. And then we started this with slow versus thorough. Those are two different things. Do not confuse thoroughness with slowness. They are not the same at all, nowhere near the same. And so understand the difference between the two. I'm going to leave you with where we started, which is where I end all of this, which is average is easy. So don't be it. And I'm going to give JJ the last few seconds here to give any final thoughts you have. And then if anybody wants to reach out and contact you, how do they do so?
You can reach out and contact me, JJtheRT@gmail.com. You can find me on Instagram, Twitter, all of the social medias, JJtheRT. Look out for me. I'm going to start getting hot and heavy in the social media world. It's time to set this world on fire.
Yeah.
Just a final thought as far as looking at distribution of therapy and your staff. You know, we look at the number of therapies that we do. And Joe and I had a conversation again, I think it was last week or so, and we hit a point that acuity can change in a breath. And I just want to leave you guys with that. Acuity can change in a breath, and let's see what that means to you guys moving forward.
I got to put that on here, man, because that's worthy of a shirt. And I'm not going to steal it from you, but one of these days you're going to have a shirt, and that's what it's going to say. I guarantee it. I'm not going to follow up with anything of that. Future respiratory therapists and anybody watching this, JJ, we appreciate you for your time today, man. I always enjoy talking to you, and I hope the people watching this enjoyed it. Let's get involved. Comments below. Ask JJ some questions. We'll come back and answer them again. In the meantime, remember, go be great.